Good afternoon. Welcome to Day 3 of the Capital Medical Center Department of Internal Medicine postgraduate course. For today's session, we will be discussing the principles and diagnosis of shock. At the end of this lecture, the viewers are expected to define shock, know the classifications of shock, understand the principles in generating differential diagnosis of etiologies in shock, and understand and apply the principles in the initial management of shock. Now, don't be so shocked. It's but normal that we define and discuss shock because we see a lot of it in our ICUs. Shock is defined as a life-threatening, generalized form of acute circulatory failure associated with inadequate oxygen utilization by the cells. It can also be defined as a clinical condition of organ dysfunction resulting from an imbalance between cellular oxygen supply and demand. The most common pathophysiology involved in shock is the impaired oxygen delivery in the setting of circulatory failure. Impaired oxygen delivery might be due to increased oxygen consumption or impaired oxygen utilization. In the presence of adequate oxygen, the cells metabolize glucose into pyruvate, which enters the mitochondria where ATP is generated via oxidative phosphorylation. However, in insufficient oxygen supplies, the cell is forced into anaerobic metabolism. Pyruvate is then metabolized into lactate with much less ATP generation. Now, going deeper into oxygen delivery, we have to find out the parameters that determine oxygen delivery. Oxygen delivery is the product of cardiac output and the arterial content of oxygen. Cardiac output, as we know, is the product of heart rate and stroke volume. Stroke volume has three major determinants: preload, contractility, and afterload. Arterial oxygen content is determined by the equation hemoglobin times 1.34 times oxygen saturation plus the product of partial pressure of oxygen times 0.003. As you can see in this equation, heart rate, preload, contractility, afterload, hemoglobin, and oxygen saturation are important parameters to determine delivery of oxygen. As shock is not only due to oxygen delivery, but also oxygen consumption, we have to discuss the parameters that affect oxygen consumption. VO2, or oxygen consumption, is the product of cardiac output and the difference between the oxygen content in the arteries minus the oxygen content in the veins, or mixed venous oxygen content. As discussed earlier, cardiac output and arterial oxygen content have not changed. The venous oxygen content, however, is determined by the formula hemoglobin times 1.34 times oxygen saturation in the mixed venous blood plus the product of partial pressure of mixed venous O2 times 0.003. These parameters are important because these parameters will also determine the classification of shock that we are dealing with. Now, let's move on to the classifications of shock. There are four classifications of shock: hypovolemic, distributive, cardiogenic, and obstructive. Let's discuss them one by one. Hypovolemic shock is an inadequate organ perfusion caused by a loss of intravascular volume, which is usually secondary to an acute process. A significant drop in cardiac preload to a critical level will cause reduction in macro and microcirculation, thereby causing negative consequences for tissue metabolism and triggering an inflammatory reaction. There are four subtypes of hypovolemic shock. There's hemorrhagic shock, traumatic hemorrhagic shock, hypovolemic shock, and traumatic hypovolemic shock. Hemorrhagic shock results from acute hemorrhage without any major soft tissue injury. Traumatic hemorrhagic shock, however, is an acute hemorrhage with accompanying soft tissue injury, and in addition, there may be release of immune system activators. Classically, hemorrhagic shock can be anything like GI bleeding, and traumatic hemorrhagic shock can occur secondary to accidents, particularly vehicular accidents, or any other form of trauma causing blood loss. Hypovolemic shock, however, is a critical reduction in circulating plasma volume without acute hemorrhage. These would be manifested in patients who have severe diarrhea or severe vomiting. Traumatic hypovolemic shock results in critical reduction of circulating plasma volume without acute hemorrhage due to soft tissue injury. These are seen in patients who suffer from significant burns, chemical burns, and deep skin lesions. For the treatment of this kind of shock, the target is to replace the volume losses that the patient has suffered. The next classification of shock is distributive shock. It is a state of relative hypovolemia resulting from a pathological redistribution of the absolute intravascular volume. That is the most frequent form of shock. Usually, the causes may be a loss of regulation of vascular tone, the volume being shifted within the vascular system, or disorder in permeability of the vascular system. There are three subtypes of distributive shock. The most common would be septic shock. Next would be anaphylactic or anaphylactoid shock. And the last would be neurogenic. Let's discuss each. Septic shock is a dysregulated response by the body to an infection, resulting in a life-threatening organ dysfunction. You may use the SOFA score or the Q-SOFA score in determining if a patient is in septic shock. Pathophysiologically, what happens is endothelial dysfunction ensues, causing dysregulation of vascular tone, resulting in vasodilation, also resulting in impaired distribution and volume shifting. The next subtype of distributive shock is anaphylactic shock. This occurs with a massive histamine-mediated vasodilation and maldistribution with the shift of fluid from the intravascular to the extravascular space. It is an IgE-dependent hypersensitivity reaction and is involving mast cells. The usual triggers for anaphylactic shock are food products, venom from insect bites, and even drugs. The final subtype for distributive shock is neurogenic shock. It is a state of imbalance between sympathetic and parasympathetic regulation of cardiac action and vascular smooth muscle. There may be profound vasodilatation with relative hypovolemia while the blood volume remains unchanged. Pathophysiologically, it may occur because of direct injury to the centers for circulatory regulation due to compression, ischemia, or the influence of drugs. There may be altered afferents to the circulatory center in the medulla oblongata due to fear, stress, or pain, or dysregulated vagal reflexes. Also, it may be caused by interruption of the descending connection from the bulbar regulatory centers to the spinal cord. Manifestations may be seen as a sudden drop of systolic arterial pressure to less than 100 mm mercury and the heart rate to less than 60 per minute. There may be obtended consciousness and the loss of spinal reflex. Moving on to the third classification of shock, we have cardiogenic shock. In cardiogenic shock, disorder of cardiac function in the form of a critical reduction of the heart's pumping capacity caused by systolic or diastolic dysfunction leads to a reduced ejection fraction or impaired ventricular filling. Systolic atrial pressure might be less than 90 mm mercury or the mean blood pressure of 30 mm mercury below the baseline value. The cardiac index of the patient may be measured as less than 1.8 without pharmacologic or mechanical support. For those who are already on mechanical or pharmacologic support, the cardiac index would be less than 2.0. Cardiac index is your cardiac output divided by your body surface area. Last but not the least of the classification of shock is obstructive shock. The condition is caused by obstruction of the great vessels or the heart itself. It might resemble cardiogenic shock in manifestation. However, the causes might result in an impaired diastolic filling and reduced cardiac preload, like in a vena cava compression syndrome, in the occurrence of tension pneumothorax, in the presence of pericardial tamponade, or in patients with a high PEEP ventilation. Obstruction may also be caused as an increase in the RV afterload, which eventually reduces LV preload. So this may happen in patients with pulmonary artery embolism, with a mediastinal mass, which increases the RV afterload, with an intracardiac mass, or with an obstruction of aortic flow, which can happen in patients with aortic dissection. While there are officially 4 types of shock or 4 classifications of shock, you have to understand that patients may manifest with mixed shock, meaning they may have more than one type of shock. So you can have a patient who has sepsis or septic shock and also have cardiac problems and complicate the septic shock with cardiogenic shock. It is important, therefore, to evaluate patients properly. In this diagram, we see that, first of all, we have to do a proper history because the history strongly influences the suspected diagnosis. For example, if your patient is a known case of coronary artery disease, chances are there's a higher likelihood that that patient will develop cardiogenic shock. So, in terms of physical examination, when a patient is in shock, these systems are the priority for evaluation: airway, breathing, circulation, disability or neurology, and exposure. In terms of airway, you might see the patient have obstruction or seesaw breathing, a muffled speech, or cyanosis. In terms of breathing, you might encounter a patient who is tachypnic, who has rhonchi, who is desaturating, who presents with adventitious sounds, and maybe even pneumothorax. In terms of circulation, your patient might present with arterial hypotension, volume loss, tachy or bradycardia, capillary refill time of more than 2 seconds, increased lactate, ECG changes, and oliguria. Neurology-wise, your patient might have altered sensorium, restlessness, or even loss of consciousness. Evaluating the skin, patient might be cool and pale, patient might have warm skin, patient may have fever, may appear flushed, and may have localized complaints or pain. As we discussed earlier, the different pathophysiology of shock, you have to determine which particular type of shock your patient is actually experiencing so that these may be corrected properly and addressed. That is the most important part of treatment, to address the underlying cause. We now move on to the initial management of shock. Now, when you encounter a patient in shock, chances are there is circulatory failure, specifically manifesting as hypotension. So, usually, the first thing that comes to mind is to give the patient fluids. Remember that fluids, since they are a treatment modality, should be treated as drugs. As you determine what particular kind of fluid to give, you should determine the dose, meaning how fast or how slow should you infuse fluids. You should determine the route. Are you giving it intravascularly or through other methods? And you should determine frequency or timing, meaning, are you giving it for more than one day? Are you giving it for in a bolus of a few minutes? And so these are important factors to determine because fluids, like any other medication or treatment modality, have their pros and their cons. And overhydration or excess fluid resuscitation might cause more harm to the patients. In terms of determining fluid responsiveness in critically ill patients, usually we make use of static markers, meaning physical examination, whether you hear RALs or not, chest x-rays, whether you find congestion. If you're lucky enough and your facility is capable, you might measure CVP are pulmonary artery occlusive pressure. You have measurement of lactic acid, and you can also measure left ventricular and diastolic area. However, these static markers are poor predictors of fluid responsiveness. Rather, it is now recommended that we make use of dynamic parameters like your stroke volume variability, or pulse pressure variability, your IVC diameter variation, your LVOT-VTI, or make use of dynamic tests such as a fluid challenge, a passive leg raise test, or an end expiratory occlusion test. Unfortunately, we do not have enough time to go through each one of these for today. This particular table might be familiar to most of you. This is taken from the Surviving Sepsis Guidelines for the year 2021. As I said earlier, most shock patients will be given resuscitation through fluids. And these are the particular guidelines for septic shock management. As a review, we can see that sepsis guidelines will recommend hydration of at least 30 ml per kilo of IV crystalloid for the first 3 hours, and that we make use of dynamic measures to guide fluid resuscitation, that we measure lactate, and that we make use of capillary refill time to guide resuscitation. Now, just a word of caution, not all patients will manifest or present as fluid responsive patients. When we discuss fluid responsiveness, it means that when we infuse fluid, our goal is to augment cardiac output by increasing the preload. However, not all patients will increase preload just by infusing fluids. Like I said earlier, excess fluid infusion might cause more harm than good in some patients. So you have to determine whether your patient really does necessitate fluid infusion or not. In studies, they say that 50% of patients manifesting with septic shock are actually not fluid responsive at the onset. In terms of hemodynamic management, they recommend the use of crystalloids, of balanced crystalloids. You may give albumin in patients who might need excessive volumes of crystalloid, but they recommend against the use of starches. In terms of hypovolemic shock, particularly those who suffer from hemorrhagic shock, of course, transfusion of blood and other blood products might be indicated. So it may range from packed red blood cells, fresh frozen plasma, even the need for coagulation factors, platelet concentrates, and maybe you can even give doses of tranexamic acid to prevent further bleeding. Now, once you have adequate fluid resuscitation, if your patient is still in circulatory failure, there might be a need to make use of vasoconstrictors or inotropic agents. So, we have here a table itemizing the different inotropic supports that we can use for patients. So, we have epinephrine, which is mostly used, it can be used in all types of shock, but more commonly is used in patients with anaphylactic shock. Dobutamine is most commonly used for patients with cardiogenic shock. Norepinephrine is the first vasopressor of choice in patients suffering from septic shock. However, it may also be used for other types of shocks who are unresponsive to fluid hydration. Milrinone is a PDE3 inhibitor, which is also used for patients with cardiogenic shock. Levosimendan is also another medication. It's a calcium sensitizer that is also used for cardiogenic shock. Now, I understand that milrinone and levosimendan might not be readily available in all centers. Vasopressin is a V1-mediated vasoconstrictor, and it has been cited as a secondary vasopressor for patients who are in need of norepinephrine, but is already suffering from the adverse effects of norepinephrine, such as extreme tachycardia. So this is my last slide for today, and I think it summarizes everything that we have discussed. If you look at the center, you see that shock is an imbalance between oxygen supply and oxygen demand. And around it, you can see the 4 different classifications of shock: hypovolemic, distributive, cardiogenic, and obstructive. For hypovolemic shock and distributive shock, the more common problem is volume. Hypovolemic shock is resulting from volume loss, while distributive shock results from volume shifts. For hypovolemic shock, you may have a loss of volume through blood loss or loss of volume through loss of body fluids. And therefore, management would be correction of the bleeding and correction of the volume loss. For distributive shock, there's 3 primary subtypes, which is the septic, anaphylactic, and neurogenic. And so for these particular shock subtype, you have to make sure to treat the primary problem. For cardiogenic shock, problem would be output secondary to problem with your cardiac function. So it might be a myocardial pump failure, and so we have to augment the function of the myocardium. If the pump failure is secondary to coronary artery disease, then revascularization might be indicated. Cardiogenic shock might also be primarily because of problems of your cardiac conduction system, resulting in brady and tachyarrhythmias, or it might be anatomic problems, such as problems with your heart valves. And so, maybe corrective surgery might even be indicated. For obstructive shock, the problem with output is secondary to extracardiac obstruction. So, we have to determine what is causing the obstruction and release this obstruction to be able to fix the problem. And so, I hope that this lecture has aided you in knowing more about shock, how to recognize it, how to determine what type of shock you're dealing with, and eventually how to start to manage it. Thank you for your attention.